Welcome, doctors. Today, we're going to tackle a core challenge in our specialty, and that's the vast and often really confusing world of cutaneous mycobacterial disease. We all see the lesions, we suspect the cause, but truly mastering these conditions, it comes down to understanding one single, unifying principle. Okay, so let's just dive right into the central question, right? How can these two organisms present in so many wildly different ways? The answer, and this is the key, it isn't really about the bacteria themselves. The secret, the thing that unlocks this entire field, is hiding inside the patient's own immune system.
So, we'll start right there. We're going to establish the single most important concept, because I promise you, once you really get this immunological spectrum, everything else, from leprosy to cutaneous TB, it's all going to fall right into place.
Okay, look at this. Everything comes down to this immunological tug-of-war. You have a strong Th1 cell-mediated response that contains the bacteria. It walls them off. This leads to localized paucibacillary disease, few bacteria. But when the Th2 or humoral response dominates, it actually suppresses macrophage activity, and this lets the bacteria just run rampant, resulting in widespread multibacillary disease. This one concept explains almost every single clinical presentation we're going to see.
Now let's apply this principle to Hansen's disease. We'll use the classic Ridley-Joplin classification, which is, when you get right down to it, a clinical map of that exact immunological spectrum we just discussed.
So, the Ridley-Joplin spectrum is a continuum, a sliding scale. It moves from tuberculoid, or TT, on the strong Th1 end, through all these unstable borderline states, BT, BB, and BL, all the way to the other end, the lepromatous, or LL, pole. And that represents the weakest cell-mediated response and a dominant Th2 profile. Every single patient with leprosy sits somewhere on this line.
And check this out. Notice how every clinical finding is a direct consequence of the immune response. At the tuberculoid pole, you have strong immunity. The body fights hard, but the collateral damage is huge. You get few lesions, but you get early, severe, localized nerve destruction. Now flip that. At the lepromatous pole, weak immunity means the body is just overwhelmed. You see countless bacilli in the skin and a diffuse, symmetric nerve involvement that shows up much later. One is a focused, brutal battle. The other is a widespread, failed containment.
Now, before a patient fully commits to one of these poles, they might show up in an indeterminate state. For these really early cases, you have to remember this brilliant clinical pearl from Dr. Bravo-Puccio's work in Peru. The 4 A's are your earliest clues for a paucibacillary lesion. It's achromica, or hypopigmented, anesthesica, with sensory loss, anhidrotica, meaning it doesn't sweat, and alopecica, with hair loss. This is a powerful, powerful bedside mnemonic.
All right, now let's take this exact same framework and apply it to cutaneous TB. What seems like this just confusing collection of different morphologies is actually perfectly predictable. You just have to realize it follows the exact same immunological rules as leprosy.
See, just like with leprosy, we can split cutaneous TB presentations into 2 main buckets, all based on the host's immunity. You've got your paucibacillary forms, like tuberculosis varicose acutis and lupus vulgaris. These happen in patients with good cell-mediated immunity. The bacteria are rare, they're hard to find. Then you have the multibacillary forms, like scrophedioma or a tuberculosis gumma, and these are seen in patients with impaired CMI. Here, the organisms are absolutely plentiful.
I want you to think of scrophaloderema as a sign of containment failure. You've got an underlying focus, a lymph node, maybe a bone, that is so packed with bacteria that it literally breaks down and fistulizes right to the skin. This is a classic multibacillary presentation, a super clear indication of a weaker immune response that just can't control the infection at its source.
And in complete contrast, you have TVC. This is a sign of a robust and effective immune memory. This happens when a previously sensitized person is re-inoculated. Their immune system immediately recognizes the threat and bam! It walls it off, creating a localized verrucous paucibacillary plaque. It's the body's cell-mediated immunity working exactly as it should. Now, that immunological spectrum we've been talking about, it isn't static. It can shift. And when it does, often during treatment, it can trigger these acute, really dramatic inflammatory events that we call reactions. And let me be clear, these are true dermatologic emergencies.
Okay, it is absolutely crucial to understand there are 2 fundamentally different types of leprosy reactions. Type 1 is a sudden upgrade in cell-mediated immunity, a shift up the spectrum towards the tuberculoid pole. This happens in borderline patients. It causes inflamed lesions, acute neuritis, and we treat it with prednisone. Type 2, or ENL, isn't a shift, it's an immune complex problem driven by a huge bacterial load in lepromatose patients. It's a systemic vasculitis, and the treatment is thalidomide. Totally different pathophysiology.
Tuberculoids are, for all intents and purposes, the TB equivalent of a reactional state. But here's the key. These are not true infections of the skin. They are hypersensitivity reactions to TB antigens that have spread through the blood in a patient with very strong cell-mediated immunity. So when you see something like a papillonocratic tuberculoid or erythema induratum of Bazine, you're not seeing the bacteria themselves. You're seeing the host's powerful immune response to them.
So you've analyzed the patient, you've placed them on the immune spectrum in your mind, and you've got a working diagnosis. Now, how do you prove it?
Your workflow needs to be methodical. It starts with your clinical suspicion, guided by everything we've talked about. For a suspected multibacillary case, a slit skin smear is a quick, invaluable bedside test. But for any case, and especially for paucibacillary disease, where you won't find organisms on a smear, a deep skin biopsy is absolutely essential. And now, of course, we have PCR, which can often find that bacterial DNA even when our stains and cultures come up empty.
And the histopathology, it's a direct window into the immunology. A tuberculoid biopsy shows you a competent immune system at work. You'll see these well-formed granulomas actively attacking and destroying nerves. In contrast, a lepromatosis biopsy shows immune failure. You just see these diffuse sheets of foamy Virchow cells, which are basically macrophages that have become inert storage units for countless bacilli.
So really, this is the ultimate takeaway. The clinical presentation of any mycobacterial disease is not random. It's a direct readout of the host's immune status. If you learn to read the skin lesions, their number, their morphology, their symmetry, you can understand the host's response. And then you can diagnose and manage these incredibly complex diseases.
And you know, this leads us to the future. I mean, imagine a day where we can rapidly measure a patient's cytokine profile or their gene expression signatures. We could move beyond just looking at the morphology of the lesions and instead quantify the patient's precise immune response in real time. That is where this field is heading, and it's all built on the very principles we've covered here today.